What Health Map does is a digital portal for tracking the spread of disease. And it does this through a variety of mechanisms, which I'm going to introduce very quickly. So we're scraping the web across a large amount of public and private sources covering hundreds of thousands of websites in many different languages. This is an automated process that's working 24/7 and capturing data in real time. So we use combinations of natural language processing and machine learning. And I'll talk a little bit about that in terms of processing this data. So natural language processing is we're looking for kind of semantic types, so information that allows us to determine data such as a location, a case count, disease name, species that are affected as well, in a kind of a programmatic high throughput way. So here's an example of some text and some semantic typing of that text. So we categorize posts. So again, we're capturing, I kind of glossed over the data we're pulling. We're pulling in news articles and online reports and government reports that are published online, any kind of text information we can capture that's unavailable on the internet. And we're doing this NLP on that data. And we're able to categorize and type this post using lots of different phrases that we built up in our ontology with a very high accuracy. So then there's a level of kind of machine learning on top of that that's able to determine the kind of the degree of severity of the information, or I don't know how to say that, but we're looking for, we want to determine, is this breaking news that hasn't been reported yet? Is this a warning? Is this old news that we've had in our database and that's already we have information on, and kind of be able to catalog it in that way. Because the nature of our site, we're reporting kind of breaking news. We really only are interested in the breaking warning categories, and the rest is not processed. So we're able to capture a large amount of alerts a day, placed in many locations around the world. And you can see here, as we have highly granular spatial information, we can plot that and visualize it on this type of dashboard. There's a level of human curation on top of everything. So while we're doing this kind of NLP machine learning approach, before anything hits the website, there are human curators that kind of vet and go over the data as well to ensure the integrity. So here's an example of the website and the mobile app on the top left. So I introduced this just to say kind of the overall approach of our group, this computational epidemiology group. We do lots of different projects that kind of both run separately from this, but also integrate back into this. But this is kind of the founding piece of work. And Health Map as a service feeds many different stakeholders. We work with many national and international organizations over the years, and it's a really great data source. So if anyone's interested in it, you should check it out. And there's a lot of good information. Okay, so quickly, that was kind of a quick overview. I'm going to talk a little bit about what I do, which is more analyzing social media, primarily Twitter, although we look at many different social media networks. And I'm going to talk today about this notion of the digital phenotype, which was read kind of before I came on. But so the idea is that there's a tremendous amount of data being generated by individuals that's related to health information or either personal health data or health information. This data exists in both real time, but it also exists as this large corpus of retrospective data that can be analyzed to give insight. Collectively, all these data are known as a digital phenotype. This is unique and unsolicited information that talks about a person's health and related issues. So the concept of digital phenotype, it's supposed to supplement traditional disease reporting, and it really allows us to expand our abilities to identify and diagnose disease. So using digital phenotypes, we can capture acute information on acute illnesses, for example, foodborne illness, which I'll talk about a little bit in a moment. We can look at chronic disease. We can investigate health-related issues such as drug safety, patient experience, and even drug diversion and abuse. And these are just a few examples. And this is looking kind of at an individual level, but when you begin to aggregate these tweets and kind of look at spatial information over a large population, you can do disease surveillance as well, and really track the spread of disease that I talked about, the kind of the notion of Health Map. So the power of a digital phenotype is it really extends beyond just this idea of identification and surveillance, and in that we're really only able to kind of redefine disease expression in terms of lived experience of individuals. I think that is really what's driving our ability to expand, beyond into a better ability to both classify and understand disease and health-related issues. So I think I'll hopefully present a little bit about this that kind of speaks to that point. And this is a concept that we published recently, which you can read more about. Okay, so wide amount of social media available. Pros and cons for all of them. I'm going to talk today mostly about, actually entirely about Twitter, but we've used data from pretty much every resource you can see on here, and I'm happy to chat about that offline. So just in general, the value of social media. So I know there's a lot of ethical concerns about using this data for research. I will say our kind of focus is only looking at public discussions and data that has zero privacy settings attributed to it. So it's our kind of standpoint that looking at this data is kind of it's our responsibility. This is public information. We should be monitoring it for health-related research and looking for potential outbreaks and potential dangerous public health conditions. So we know there's a massive volume of discussion of health, patient-reported outcomes. We don't know the level of depth and quality, and that's kind of what we were interested in researching. I talked about this kind of earlier, but our work and others have shown that there is really a unique component to this data that's not captured in the data sources, and it really speaks to the utility of using this type of research. And of course, it probably shouldn't need to be said, but this should always be thought as kind of a supplement to traditional surveillance. Should not replace it. There's still really room for both in this type of research. So there's a lot of areas that we're using social media for health research right now. Here's just a few that I'm actively working on at the moment. I'm going to talk really quickly and briefly about two of them. So foodborne illness and sleep disorders. I'm going to start first with sleep disorders. So sleep disorders are a growing problem that are affecting many people in the United States and worldwide. We wanted to see if we could use social media to better understand this disease and characterize the behavior of people who are suffering from it. So really, are we able to identify people who are suffering from sleep disorders based on the online behavior that they exhibit? So we began first using kind of this retrospective analysis using a large corpus of tweets that we've collected over the years that have highly detailed spatial information associated with them. And we just wanted to see, we came up with a list of keywords associated with sleep disorders, kind of clinical guidance working with us at Boston Children's. And we said, let's just search the entire database looking at North America and just seeing how many tweets contain one or more of these words, and just see kind of a spatial and temporal distribution of those tweets. So I'm showing that here, which is showing poorly, I apologize. But what we're seeing here are about 1.5 million tweets over a 2-year period centering over North America. Every dot is an individual tweet, and the color is the user's local time at the time the tweet is posted. So dark blue is a nighttime tweet, and orange is a daytime tweet. Just high level, what you're supposed to be seeing here is that the tweets roughly correspond to population density, and you can see that it's things that are happening kind of all across North America, roughly. And most of the tweets are happening at night when you'd expect people to be complaining about sleep issues. If you look at some of the words that are predominantly used in these tweets, again, words that are consistent with people that are complaining about having a sleep problem. If you take some of the individual keywords that we use to capture these tweets and look at their distribution over time, again, the time of day it was posted, again, you see this distribution where most of the tweets are happening overnight, as you would expect, kind of confirming that these people might really be not just complaining about it, but suffering from these sleep disorders. Interestingly, looking at this database, you can see that, so these are individual users, I think 7 different users over a 2-year period, and the kind of a plot of the number of tweets over time. And you can see some users are kind of chronic sleep problems that they're complaining about it, or at least they're complaining about a sleep problem, which indicates they might have a chronic problem over a long period of time. Others kind of spike up and have this brief kind of more of acute phase. I think that speaks to the desire to doing a more of a prospective analysis where we're tracking people for a much longer period of time to see if we can understand their behavior as they're kind of prior and as they're entering these phases. The reason I'm doing this retrospective analysis was originally just to see if Twitter was a good resource to do this kind of work, and we were happy with these results, so we went forward with a kind of a smaller prospective analysis, which I'll go over really quick. So we set this up as kind of a case control, where we were looking at, we want to identify users on the case side that, again, were posting, had a tweet that had at least one of these sleep-related keywords. We manually curate these tweets to look for users that we believe were real people, and not like a joke account or a bot or just a a news article or just someone not making a legitimate claim about a sleep issue. This is a subjective process, but it was done via manual curation. Here are some of the people that we've identified by this method. Okay, and then as we once we identify these people, we wanted to then pull their timeline and do and profile information, do more of a longer analysis. So the goal there was not to just look at the tweet that we captured them with their complaint about sleep issues, but look at the behavior prior to that as well. So all of their posted behavior, not just tweets that complain about sleep issues. And we had about 900 people in this group. I'll talk about the analysis in a moment. For the control group, we're looking for people who did not post about sleep-related keywords. Manually curated again to identify what we believe to be real people. We again pulled their timeline information and profile information. And in this case, we rejected anyone that mentioned a sleep issue at any point in their timeline. And that was just an attempt to really ensure that the control group was someone who didn't complain about a sleep issue. And then we went ahead with the analysis, again, about 900 people. So we looked at, this is just some of the information we looked at, but some user data, their location, kind of their online behavior in terms of the network they had, in terms of posts, friends, or followers, the device they posted from. In terms of timeline data, we look at the time of post, the day of the week it was posted. We look at sentiment. So sentiment is kind of a measure of how positive or negative they are based on the language that they're using in their tweet. This was done via manual curation method using Amazon Account Turk, which is a crowdsourced approach for curation. So high-level results, we're looking here at, in red, the sleep users, and in blue, the control users. And we're looking at the distribution of posts that this group made during different periods of time during the day, so each hour during the day. And it takes a minute to get oriented, but what you're seeing here is that the sleep users, the case, the red line, were posting more of their overall posts at night versus the control users who are posting more during the day. Which again kind of confirms or at least suggests that we're really looking at two different populations here. And it makes sense given the way we selected them. So if you look at kind of a higher level, more of a complete analysis at a high level, without diving into all the specific tables, in comparison to the controls, we found that these sleep users were significantly less active on Twitter, so they were posting less in general. They had fewer friends and they had fewer followers. And as I showed you before, they were more active during sleeping hours and less active during the day as compared to the controls. And we thought this was, this was interesting. I mean, going into this, one of my hypotheses was that people who were having sleep issues and posting about it were people who potentially were hyperactive online and posting all night long on their phone, and that might be, why they couldn't sleep. But I can't say that they're not on their phone all night or on their laptop all night, but they're certainly less active in general, have less of a social network, we found it to be interesting, kind of surprising. As well, in addition to posting less and having less of a social network, they also had a lower sentiment in their tweets, so they're much more negative in the content that they post. Suggestive, this doesn't prove anything, but it's suggestive that there might be a relationship between sleep and psychosocial issues. People have hypothesized and provided some evidence in other media, other frameworks for there being a link between sleep and depression, and this is another piece of evidence that points towards that. Again, needs a much more thorough investigation, but a very interesting result. So you can read more about this work in JMIR. It was published a few months ago, but I'm going to move on just in the interest of time. Okay, so the last thing I'm going to talk about is using social media to track foodborne illness and better provide better information to public health departments. So we know that there is a really underreporting of foodborne illness by traditional mechanisms, and we'll talk about why we think that might be in a moment. But if you look at, and this is from a few years ago, I think, but the trend stands. If you look at what's officially reported to the CDC, you have about 1,000 reports in the US per year. If you look at complaints just captured by Health Map, you see 10,000. And yes, there might be some repeats in the Health Map reports, but I think this just, again, suggests that there's a lot of information out there that might not make it to the official reporting source. Here's a distribution just kind of seeing foodborne outbreaks in health map, and I think this is a few years old, but again, the point stands. I'm going to quickly introduce one study that a colleague did before moving on to some current work we're doing, and that was to look at Yelp data to get a better sense of if this type of social media data can be used to inform food poisoning cases and general research on food poisoning. So there's a lot of content on Yelp that people who post who claim to have gotten food poisoning. Here's an example of one individual who had a really bad time, I think, eating food. And in this study, she looked, my colleague Elaine looked at New York City over a 6-year period, and she looked at the food type that was implicated in the review that where someone complained of food poisoning, compared that to the known distribution of food poisoning from the CDC across all food types. And you can see these charts look almost identical. It looks like it was made up, but it's not. And I think this just speaks to the fact that, people might not just be making stuff up on Yelp. This data might actually be useful, and it really is corresponding to what is making it at a much lower level, but making it to the official sources. So we have colleagues out in Chicago who decided to see if they could do this using Twitter. They got a lot of press last year. This is the paper that came out of it. But essentially, they were trying to, they were tracking people who posted about food poisoning online, reaching out to them for more information, and trying to use that as an official report rather than waiting for someone to file a real report. The problem with filing these real reports is that typically a lot of public health departments are like 6-page PDFs that nobody wants to print and fill out and mail in. And it's just a really tedious, annoying process to, it's a lot more attractive and easier to complain about it on Yelp or Twitter and then just forget about it. Unless you get really, really sick or in the hospital, it's not going to make it to the official reporting source. So this was a way to kind of capture that. We wrote a grant for Twitter. So Twitter had a data grant last year at this point, and we wrote a grant asking, proposing to do this using Twitter data ourselves, using a much more kind of rigorous machine learning approach that was based on a lot more historical data to build up a really good classifier that could identify potential food poisoning cases from irrelevant cases that people want to talk about food poisoning. So we were awarded the data grant. We're the only one of two in the U.S. Given about 1 billion tweets, and we did just that. We built up a classifier that we thought was really robust. And so now we built up a dashboard that we're pulling in every tweet that comes in that mentions anything to do with food poisoning. We're classifying it, determining if it talks about food poisoning or not, if we really believe it's a real case of food poisoning. And then we're making that information available to public health authorities. So right now we're piloting in a few cities. We're piloting in St. Louis. We're in discussions with Chicago and in a few other cities for them to actually use this dashboard to interact with users and treat this as an official report. Again, it was based on about 5 years of retrospective data, 4.5 years, and we feel that the classifier is pretty robust. Tweets are coming in. 1 to 4% of tweets are geocoded, have GPS coordinates, so that means they actually have a very granular line coordinate from where the tweet was posted. That's great. We know exactly where it came from. We can report that to the city. For the rest, we are geocoding ourselves based on information that the user posted out in their profile and content of their description. We can geocode about 70 to 80% of all the tweets in this that we're pulling in with food poisoning. It's hard to determine how many are really true. This is city level geocoding. It's hard to determine how great we're doing, but I think it's probably about 50% based on prior research in terms of accuracy. So here's the shot of the dashboard, which I'll skip over really quickly. If you drill down, you can see this is the case where there's GPS level coordinates. Someone complained about getting sick at their school. The GPS coordinates really gave a lot of context to what school they were talking about. So sorry to that university. It allows, again, follow-up by public health departments. Here's another example of a tweet. I believe this is St. Louis. Where the user's complaining. It's not super specific where where they might have gotten sick, what they're complaining about in the context of in the nearby vicinity of the city. So the point here is to lead to better citizen engagement. So public health department via this tool can really create a response text to the person. Say, we're sorry you're sick. We're here to help. Please follow this link and fill out more information so we can actually follow up and treat this as an official report. And entirely voluntary, but the citizen who complained can fill out this report. We're still working on kind of the construction and how much questions will be asked, but basic information about where they got sick, what they ate, some of their symptoms, and some contact information if they want to follow up. This will serve as an official complaint that the city can follow up on. So some high-level numbers. We're looking at a few cities just in terms of bandwidth. Coming in, we're seeing hundreds in some of the smaller cities and up to 1,000 in some of the larger cities, and we look in the UK as well. Okay, so I'm going to pretty much end here. We're doing pilot testing in St. Louis right now. We're in the middle of integrating data from Yelp so we can get more structured information about specific restaurants. We're expanding to other local health departments, and we're piloting some data sharing with the national government agencies. So if it's you ate food that was tainted from the supermarket and tainted from its source, that's what the national government wants to know. And the local department, local health department, has less ownership over that. And we're also working internationally with a few agencies to see if we can help provide this tool. So sorry that was really quick. I just want to thank some of our group members for helping me out all this work. And I probably won't take questions until afterwards, so come chat. Thank you.
I can take a question, I guess, while we load up.
So it wasn't clear that response email saying sorry, could you fill this out? That would be going automatically to that?
So it could be. We're not doing that. So the dashboard is the city itself. In this case, St. Louis has login credentials. We don't. And they're able to decide, based on the classification from our classifier, is this food poisoning? They read all the tweets and they can decide, I want to respond to this tweet, and they can actually construct kind of a dynamic text. We had some suggestions, but they can send whatever they want. I think if they become very comfortable with the classifier and truly believe it's working up to their satisfaction, it could be an automatic approach. I will say a city like St. Louis is having a few a day tweets coming in that fit this criteria, so it could be a manual process. If we're looking nationally, I think it needs to be more of a programmatic approach.
Would people be kind of disturbed, like, why am I getting this?
Yeah, so Chicago was a nice beta tester for this since they've done this live prior to our collaboration. And most people are actually pretty happy with it. You think that they would be annoyed, and some are, but I think if you're complaining about being sick and like mad at a restaurant, they're happy that the city cares enough to go follow up on it. You do get the kind of creep out Big Brother vibe. We wouldn't reach out to them. It would be the public health.
But basically, they're just saying, look, we observed this on this public resource. Therefore, we have a method of contacting people.
Exactly. And if they don't want to respond with more information, nothing comes of it. It's if they then say, yeah, you know what? Like, here's the restaurant. This is what I ate and really wanted. As I said, to fill out a PDF, that's like 5 pages. No one's going to do. But when you reach out to them and say, just give us like 2 pieces of information and we will go investigate, they're a lot happier about it.
And the response is via Twitter?
It is via Twitter, yeah. It's a message up, direct response.
Yeah. Doesn't pass out to email.
No, they can enter their information for follow-up afterwards. Okay, thank you.
Thanks again, Jared.
Thanks, Steph.
So our next speaker is Mauricio de Santillana. He's a physicist and applied mathematician with expertise in mathematical modeling and scientific computing. He holds a master's and a PhD in computational and applied mathematics from the University of Texas at Austin. Currently, he's a faculty member in the health informatics program at Boston Children's Hospital and an associate at the Harvard Institute for Applied and Computational Sciences. Turn it over to you.
Well, thanks for the invitation. I'll fly. So just it'll be more like a documentary of what we do, more about, and less about the details or the technical details. So the work that I'll be talking to you about involves a lot of people, and I would like to give credit to all of them. And also, I'm not a medical doctor. And since we're using data that concerns potentially your privacy, I respect your privacy. We're only looking at aggregated data that does not involve tracking you specifically. So we're in an era of big data, and the goal is for many people to use all these available data for predictive analytics. And specifically, I'll be telling you about some of this work in medicine and public health. This slide was shown to you by Jared, and I usually So I changed this slide. So Health Map gathers information from everywhere and maps when and where. And what we're trying to do is put a y-axis to that plot, which is exactly like how to track, what's happening when and where and how, if that makes sense, or putting a number to tracking the disease incidence. I'll show you this short video, and what you will see is a black signal, which is what has been verified by the Centers for Disease Control. And you'll see a blue and a red, but you see three different curves beside the black one. And that's what we do in terms of reporting how things will evolve in time ahead of the traditional disease reporting mechanisms that we have. As you see, the goal is for these blue, red, and green plots to track the black line. So some do better than others, and I will not talk much about this plot because I'll be telling you more about this, but just to give you a sense of what we're doing, we're trying to report back to public health officials and the population the situation, whether a specific ongoing epidemic or pandemic is taking place, and what are the levels quantitatively. So one of the earlier players in this arena is Google Flu Trends, which now has discontinued. Some of you may know about this or not. And so I'll just tell you briefly. So this is kind of the same plot, except that not animated, of what I showed you before. Google was using Google search patterns on the web to determine how many people were looking for, say, fever or flu or symptoms and so on. And the goal was to use that as an independent variable somehow and be able to predict how many people would show up in a hospital with an respiratory illness. And so they were quite successful at producing this product. It made it to the news. But basically, the very first year it was launched, it failed drastically because of the H1N1 pandemic. And then they revised their methods, retrained their algorithms, and the following year they ran it. It failed again, so it got a lot of bad press. And lots of people said, well, this is the end of big data for public health. We shouldn't trust Google or anyone to be telling us what's happening based on what they're observing, and a bunch of press. Everyone was against big data. That's the bottom line. But we looked at the inner works of Google Flu Trends with an undergraduate student from Harvard. And we noticed that it was impossible to get access to their independent variables. So we could not even reproduce their methods at the time. But they were sharing some very low quality data that could be used as a proxy. And of course, it was designed so that you could not compete with them, right? But we showed, and this ended up being a paper, that we could improve their predictions even with their low quality data. So this, of course, made it to the news because our plot was, so the blue line is the one produced with our method, and the red was Google Flu Trends. You may not be able to see the red dotted curve, but the bottom line is that our method was better, right? Even with lower quality input. So it made it to the news, and eventually Google acknowledged us as a new method that could be used in their own engine for producing predictions. So we were quite happy about that. At that time, we established contact with them. Again, Google Flu Trends was heavily criticized by another team from Harvard and Northeastern. And recently, we made further improvements to the methods. This work was just accepted to be NAS, and I won't, as I said, I'll fly, right? But so when Google decided to shut down Google Flu Trends, this was on August 20th of this year, so like a month and a half ago, they announced that they would share, that they chose us as one of their partners, so they will share the raw data, the volume of searches in a given geographic region with weekly resolution. And so now we're given the opportunity to provide a more reliable service and to put resources into that. The goal, of course, is to do it well and not disappoint the public. And so far, we've shown that our methods are robust enough to do that. And so this just reinforces what I just said. Back then, we didn't know if Google was going to partner with us, so we did a lot more work about trying to use other data sources as predictors of epidemics. And flu is chosen typically because it is very well documented in the US at least. So it's a good benchmark. If you can do it well for flu, then you have a hope that you might do it well for other diseases and locations. But if you cannot do it well for flu, then that's not good. So we partner with UpToDate, which is a company that provides a service for all medical doctors. So when you go to your medical doctor and they don't remember whether a drug they're going to prescribe to you conflicts with some of your previous sickness or whatever your body is experiencing. So they go online and they search, and instead of using Google, they use this service that has been curated, has been verified by other medical doctors. So whatever shows up there has been verified. You don't get like anything that could be unreliable. So when we partnered with them, we ran similar models as if this was like the volume of searches from Google, and we produced really accurate estimates. Again, remember that these estimates are produced ahead of time, and that's their utility, right? So we produce these estimates 2 weeks ahead of what the CDC will report. So that gives us an opportunity to act if there are some levels of disease in the population that are not normal. So then we have in-house as part of HealthMap, there's an app where you can sign up and then report if you're sick or you have a specific set of symptoms, and the app maps all the responses from the users, eventually producing a map like this. And we wanted to see if this crowdsourced model had any ability to predict flu nationally, and we showed that it did. We had to do some filtering, some time series analysis to smooth the signal and so on, but we showed that it was a very good predictor of the flu as well nationally. And now we're doing it in different regions of the US, and this is where the spatial aspect starts to pop up. So we can do this in multiple locations, and the question becomes, how do we link, how do we share information across locations in time? And that becomes a spatial temporal modeling effort. And we're now doing just in very specific nodes or locations, the analysis in time. And we're now thinking about expanding in real time, doing predictive analytics that take into account the spatial autocorrelation and so on, which you're experts on. We also partnered with an electronic records company, and they would send us nearly in real time what doctors are prescribing to their patients. And using their data, we also came up with a very accurate algorithm to predict flu. And again, this flu, that's a baseline for establishing the validity of our approaches. I'll keep flying. We have also used Twitter. So as you see, we just pull data, we harvest data, but now the aim is to really put a number into our predictions, not just location, not just time, but how it is evolving in time and how likely it is that it will get into a specific scenario. So I'm jumping ahead. We've shown additionally that HealthMap is pulling data sources. It's pulling information from data sources like news or health bodies like the World Health Organization. And so we showed in this paper that during the Ebola outbreak, there were some estimates that the world would see approximately 1 million people sick, and people started panicking. And what this plot shows is, so the black line is a reproductive number, which shows how many people will get sick as a consequence of being in touch with another person who's sick in a given population. Mm-hmm. So to some extent, it summarizes the interaction of sick people with others as observed in the population. And we managed to show the red dots or the purple dots are news reports that suggested that something, for example, like a massive, like a burial happened and massive numbers of people showed up and touched the body as part of the culture in Africa. And so that really made cases emerge. And but then when countries like Sierra Leone started, healthcare efforts to prevent transmission by education and so on, which are the events that happen, again, the vertical lines are weeks. And so all the other colors are events that were reported on the media that were suggesting that something good was happening. And when I say good, was aiming at reducing the number of people being infected. And we see a decay in the number of people who are being who are getting sick. That gives us a sense that we could use also the media to modulate our predictions, so that we should not ignore data that comes from media sources as well. We're doing some efforts about predicting flu in Boston accurately. We have partnerships with, as I mentioned, this is a plot that I created on Monday in conjunction with health department from Boston. And again, you can see our predictions here from Athena Health, and they're ahead of time. Athena Health is an electronic records company. At least from May on, and we were just given this portion of data from the CDC, the local CDC. So this sort of shows you that we can go ahead of time and predict what may happen. I mean, this is not very interesting because it's a low flu season, so nobody cares. And then we've done some work additionally to try to understand, so we keep learning from more data sources that could help us predict epidemiological outbreaks. And the question is, we keep bringing data, is it making us more capable of making decisions that are appropriate? In other words, we have more data, more information, but is this increasing our knowledge? And so this is a problem that has certainly multiple fields, such as movie selection. When you guys log into Netflix, there's a predictive algorithm that says it's this time of the week, it's this day of the week, this time of the day, it's likely that John will want to watch a certain movie, right? And this is also done in the stock market to predict, is the stock going to go up or down? There are multiple ways to do it. And the question is, so you have 5 predictors, what do you do with that information? Like, is that useful for, right? So we had in our hands a similar challenge. We were getting data from everywhere. And so we were asking, is this better or worse? And as many of you know, if I had this jar here and I had counted jelly beans and I asked you how many jelly beans there are here, the median of your answers would be closer to the actual number than any of your predictions, right? So with that same principle, we said, let's take an approach, like an ensemble approach. And so we showed, in fact, that when you combine, so this is the performance of each row shows you the performance in some metrics. This is the correlation with the reported cases from the CDC. So the higher the correlation, the better. And everything else, the lowest is the better, because it's the error or the discrepancy. And as you see, when you combine all of them, the accuracy in the predictions gets just really, really good. In other words, that combining information from multiple sources makes sense. And so this is graphically what it looks like, the red line. It's perhaps more useful to look at the errors. The red line is just smaller. So we thought we're getting good at even forecasting. So this is an effort that, again, will soon involve a spatial component. That's why we're trying to reach out also to this community. And I think, so I have a lot, like many more slides, but perhaps I should, well, I should finish here. So we're replacing Google Flu Trends. So hopefully this website will be launched in late this week or early next week before the flu season. And you'll be able to click on the map, the region where you're interested. And of course, the regions that will be available will not be big because we don't have epidemiological data. In this country specifically, the data is owned by each state and by each city. So if you want to get access to their historical data, it's a fun process.
Yeah.
I'm saying fun because I'm being recorded, but you might interpret that in a more realistic way. And so for the whole US, we can, as I'm showing you like multiple data sources there, but eventually you'll click on Boston and you'll see what may happen in the next couple of weeks. And that will, if you're traveling somewhere, ideally we aspire for you to check, oh, I'm going to Detroit or, whatever your business takes you, and you can check this as your weather forecast. Say, oh, I need to wash my hands frequently here, or who knows, something like that. Yeah, I'll end here, and I'll leave 100 slides left for another occasion. I guess we need to leave the room, right?
Well, we can take questions, and if the next group comes in and moves us out, then we'll leave. Like I said, with the schedule, there's conflicting. Outside the room, it says it's available till 3, but online it says there's someone coming in at 1. So I think we take questions and just go from there. If you do have to go, make sure you grab a lunch, which are outside the room on the right. I've got a question to start.
For me or for Jerry?
For you. So your flu predictor looked like false spikes was the biggest problem, or what's behind that? Have you been able to? And then I saw another slide that showed you had a false spike adjustment or some a spike adjustment or filter or something like that, and maybe.
Yes. So
talk about
why
that might be.
Let me see if I can pull the website that we're using, just so that we can talk about specific signal. Yes, it is a problem, but it's not that big of a problem in certain signals. So in other words, if you use electronic health records, it's very likely that you won't see like artificial spikes. But if you use Google searches, since people tend to sometimes panic, they may start looking at more.
So it's more of a panic or kind of a hysterical response.
Right.
Online.
Right. So I'm gonna pull this up. This is not the best platform yet, because this is the current website, which we're perfecting, but for our purposes, I can turn off, for example, I'll turn off Google Trends, Google for Trends, and I don't ask you to know what this is, but so if I leave only these two, you see that, so this is the CDC, the black line, and these are our predictions in the website. So they're pretty well in line, right? Now, if you look at, for example, and I have this bad taste to keep banging on Google Food Trends because they no longer exist. So, and we're their partners, so it's like, right, right? But just to show you, right? So that they had problems with huge spikes, and they explained it as a consequence of panicky searches. But we showed that actually you can control for that, and you can be okay. Did I answer your question?
Yeah, no.
Okay.
Panic is the answer. And
Okay.
perfect. So, yeah.
Yes.
So last year, it was, DARPA was running a contest for the chikungunya,
Chikungunya, yeah.
yeah, chikungunya virus. Did you guys do any monitoring for that? Whether
Yeah,
it's
so
reported or not?
in our team, there were people who worked on that a little bit.
Did you find that it compared well with, or were the numbers too small?
Yeah, so diseases, there are multiple issues. So the question is loaded in the sense that many of the data sources that I'm showing you may or may not have a counterpart in different countries. So, in the best case scenario, you have multiple data sources there and you could compare. I did not show you the modeling behind. There are some predictions that are, these are not mechanistic predictions. In other words, we're not understanding why it's going faster or not. This is merely a thermometer that says, just temperature and then it's hotter, like more people are getting sick. But in terms of modeling, there are multiple approaches. And the bottom line is that multiple diseases have different dynamics, and that may make it challenging to just copy the same approaches. But more from the mechanistic perspective. From the thermometer approach, right? The social media thermometer, like just taking a snapshot in time of what's happening, that seems to be fairly reasonable in terms of transferability, if that makes sense. Let me just show you. Oops. Let me see if I can get back to my PowerPoint, because so I have a slide about chikungunya, I just didn't show it because. But we're using Twitter for chikungunya, and it has been helping with this. Perhaps I can show you here. Maybe this makes sense. So this is a plot that shows you the traffic in Twitter and how it tracked at the very beginning reasonably well the increasing cases, but then people seem to lose interest in tweeting about it, and yet the cases kept going up. And then, so just this is just a video of based on Twitter of what was happening according to tweets. Want to pretend like we own the room for some seconds? Yes.
Yeah, I was actually going to ask about the lag of media indicators. Is you're, if I understood correctly, suggesting that you're looking at 2-week lag for CDC.
Correct.
Measuring.
Yes.
So you just mentioned here that Twitter, we're having a week's lag. And for the other media,
Oh, no,
are they
so
real time or are they?
Everything is real time.
Okay.
Or near real time, if that makes sense. Even Twitter, except that for the slide that I showed, did you read what the part that it said 1 week lag?
Yeah.
Yeah. So that was just the best fit. That means that we got data from Google earlier. So, Twitter preceded the number of cases. In other words, Twitter could have been used to predict the number of cases, at least in this time period.
Well,
I don't know if I'm making sense.
So the tweets are happening at the time or subsequent to the time of occurrence, right? So CDC data then, 2 weeks later says this happened, this was reported at this time.
Yeah.
So
what we're seeing
is the media indicators real time, or do they have a lag as well? You suggest in this case that there is some lag, or are they always real time?
Yes, so let me rephrase it. So Twitter was happening, and I chose to move Twitter forward in time, just to make it overlap with this curve. But if I were plotting Twitter without the lag, it would be shifted to the left.
Okay, so
which means say that again.
So which wouldn't be a good.
No, it's a good predictor.
No, it's a good predictor because Twitter people were panicking and they were tweeting before going to the hospital. So a week before they went to the hospital, they were tweeting. That's one way to see it, right?
Yeah. Occurrence means they show up at the hospital, not that they get sick.
Right.
So I apologize, I'm going to have to interrupt.
Yeah.
We do have another group coming in. They're patiently waiting outside.
Okay.
But please, there's lunch outside and we can continue the discussion mingling in the atrium. So once again, guys, thank you very much for speaking.
This is yours?
Oh, yeah.
Yeah.